Good afternoon, everyone. Thank you for joining the Obesity Care Advocacy Network today for a live webinar titled, A Closer Look at the Impact of Obesity Throughout One's Lifetime. I'm Joe Naglowski, your moderator for today, and I'm the president and CEO of the Obesity Action Coalition, a nonprofit organization formed in 2005 dedicated to elevating and empowering individuals affected by obesity through education, advocacy, and support. I'm especially passionate about improving access to obesity care, as well as challenging the weight bias and stigma so many of us who live with obesity face on a daily basis. I also am honored to serve as the co-chair of the Obesity Care Advocacy Network, and it is this group, which we fondly call OCAN, that brings us together today. OCAN is a diverse group of organizations that have come together with the purpose of changing how we perceive and approach the problem of obesity in the United States. We advocate for a continuum of obesity care, including evidence-based treatment and prevention options. Today's webinar is the first in the OCAN summer webinar series about obesity. We'll set the stage to understand obesity across the lifespan. Later webinars, hosted by the YMCA of the USA, will focus on the role of community partnerships in addressing obesity, and this will take place in July. And the final webinar, Supporting Children Physically, Mentally, and Academically as they re-enter a traditional school year, will take place in September. I'd like to start today's panel, which represents some of the leading experts on obesity throughout one's lifetime. So Heather Hodge is the Senior Director of Community Health at the YMCA of USA. In this role, Heather provides support for the Y's efforts to help all community members live their healthiest lives through improved lifestyle health and health outcomes. In this capacity, she has significant experience with pediatric and childhood obesity. Dr. Ricardo Correa is the Program Director for Endocrinology, Diabetes, and Metabolism Fellowship, and the Director for Diversity on General Medical Education for the University of Arizona College of Medicine, Phoenix. He brings a wealth of knowledge about how the social determinants of health intersect with obesity care. And last but not least is Dr. Catherine Katie Porter-Starr. She's an assistant professor of medicine at Duke University School of Medicine and a research health scientist at Durham VA Healthcare System. As co-director of the Duke Center for Aging Clinical Nutrition Laboratory, her research and professional experience focuses on nutritional issues in understudied older adult populations at high risk for chronic health conditions and functional disability. So before we dig into our discussion about the impact of obesity through one's lifetime, I want to remind everyone that we'll take questions from the audience later in our program. You can submit a question for our panelists at any time during the conversation. If you'd like to ask a question, please open the chat box and send us your question along with your name and affiliation. We'll get to as many as possible at the end of the session. As a friendly reminder, please note that today's conversation is on the record and it is being recorded. Links to the recording and additional information will be sent out after the event. Now, we'd like to kick off our panel discussion with an overview of the problem of obesity in the United States. So Katie, I'll start with you. How do we define the disease of obesity? And can you talk to us about what obesity is and some of the factors that cause obesity?
Absolutely. Thank you, Joe. And thank you for this opportunity to be with you all today. So I think it's first and foremost, it's important to understand that obesity is a chronic metabolic disease that's characterized by an increase in body fat stores that really consequently is going to elevate the risk of metabolic diseases, cardiovascular disease, and mortality. But what's really important is kind of the factors that contribute to obesity. So obesity results from really the interaction of environment, development, genetics, and behavior. And it's not just one or the other, it's a combination of all of these. And so because there's really not one cause of obesity, a multifaceted approach is really needed at the individual, organization, community, and public policy level to really be able to combat this epidemic. So in regards to how obesity is defined, there really is currently a lack of consensus on the best way to define obesity. However, as most of us know, most of our healthcare providers are going to use body mass index, which is looking at height and body weight. So BMI is the prominent measurement used in our healthcare system, and a BMI of greater than or equal to 30 kilograms per meter squared would be what we would define as obesity. And again, BMI is based on height and weight, and it does not take into account that body composition component. And so if someone has more muscle mass, their BMI may be higher, then you would expect they may actually be considered overweight than if we actually looked at percent body fat. So percent body fat is another way to determine obesity, and the American Association of Clinical Endocrinology really recommends the use of the World Health Organization thresholds, which is 25%, greater than 25% in men and greater than 35% in women. Now, the last one that I want to talk about is really waist circumference. So waist circumference has also been used as an indicator of visceral adiposity or central adiposity or abdominal obesity. And the World Health Organization recommends those waist circumference thresholds of greater than 102 centimeters or 35 inches, as most of us would be able to understand that. And that's in men, and greater than 88 centimeters or 40 inches in women. And so again, this is really a surrogate of that visceral fat or adiposity. And I just want to say that it also should be noted that there are differences in BMI and waist circumference cutoffs for different ethnicities. And so that's also important, that we have to remember that we're not all the same, and that there will be differences depending on race and ethnicities, and something that has to be considered as well when we're thinking about how obesity is defined.
Thanks, Katie. And so, Ricardo, I'll come to you next. It's clear that our diagnosis and treatment of obesity must be rooted in science. What does science tell us about how to effectively treat obesity?
Yeah, thank you so much, Joe, and thank you for the invitation. And I want to echo many of the things that Katie mentioned, because to treat obesity, we have to look at a multifactorial setting. It's psychosocial, physiological. So there are multiple things. And one of the important things that we didn't know many years ago was that the adipose tissue, or the fat cell, is an endocrine organ. So every time that you try to kill the fat cell, they will try to defend themselves and produce some hormones to prevent that they die. So there is multiple things that are happening in the body, from all the inflammatory process that is happening because of this fat cell growing, not control, to the trying to kill them, and they are trying to defend. So there are multiple ways of treating obesity. And the most important one is lifestyle modification. Diet and exercise are the keystone of this, but we know that this is not enough. There are a certain amount of people that will try diet and exercise, and they are not going to achieve this goal. The other thing here is the stigma of even from the medical profession that, oh, you're obese because you don't do diet and exercise. Many of these patients do diet and exercise and they don't lose weight. So we have to delete this stigma. Then there is the other setting that is medical management of those of obesity. And in medical management, we focus on pointing out into that control setting that is in the brain, that the way that we can reduce our thermostat, so we can not put more weight, and we can start losing weight, and making those hormones that are produced by the fatty tissue not good, so they don't work. And the other stage is the most effective way will be in certain patients that have criteria, go to surgery. And the surgery have demonstrated that also, not just by cutting the GI tract, the gastrointestinal tract, but also there is a modification in the production of these hormones that will make you lose more weight and will make you keep those weight down. So there is a hormonal component that I can tell you 20 years ago we didn't know about it, but there is a hormonal component that we need to address. And it's not just telling the patient, hey, lose weight by diet and exercise. They will not be able to achieve it.
Thanks, Ricardo. And I think that, that your opening comments there really stood out to me, because as a person who lives with obesity, and when you hear the words that your adiposity, your body fat is actually fighting back, through your hormone system, oftentimes many of us who've started a diet, do well for a relatively short period of time, and then we blame ourselves because we're not being as successful over the long term. But the reality is that's biology, right? That is actually not about personal fault. And I think that's a really important message, and something that has changed, over the last number of years as we've better become to better understand the science. So Heather, I'm going to jump to you now, and we're going to talk about childhood obesity, something you and I both are passionate about. And so I really will say there are pretty significant worries that the rates of childhood obesity are rising dramatically, kind of due to the pandemic, right? Due to the anxiety and the depression and lack of activity opportunities that took place during the pandemic. So can you talk about how these conditions are related and why it's so critical to intervene at an early age? What are some of the challenges we're facing when we're trying to do so?
Sure. Yes, Joe. While we're talking about this with a focus on childhood obesity, the public health emergency has led to a variety of additional challenges that we're going to have to work through, not just for young people, right, but also for adults. But we'll focus this on young people. So sedentariness, the screen time, taking our education environment from an in-person to that remote learning just caused even further sedentary behaviors, and then minimal social interactions. And we're also starting to see more around what youth were eating during the pandemic. Maybe not, because we've got sometimes multiple generations in the household. Sometimes parents are trying to work at the same time. The internet bandwidth was one thing, but the meal prep and meals that were being consumed weren't always being supervised, even if everyone was under the same household. So all of these things can compound anxiety, depression, weight management. They just continue to be additional challenges that have to be unpacked and addressed. And as we start to emerge from the public health emergency, it may take our young people more time to reconcile some of the words of caution and safety practices that we've been doing for the past 15 months with the concept of return to normal. Especially when you think about some of our young people may not yet be eligible for the vaccine. So how do you manage that within your own household, and not masking, all these things. Like, they're all things that can impact that anxiety and depression level. And so in the why, we've been talking a lot about how we apply some of our trauma-informed care and mental wellness practices, specifically with youth, what that looks like in our camp environments and our out-of-school time supports. Many YMCAs created virtual learning labs so that these kids were going to a place for the virtual learning and having opportunities to be physically active. And then also thinking about how our own healthy eating and physical activity standards may need to be modified, not only to address this, quote unquote, return to normal, but also to think about just the deconditioning that's happened across the entire lifespan, all of us during this time period. And what does that look like, especially as it relates to youth? So as we're engaging, we're able to make sure we're tailoring interventions to the appropriate level. While, I completely agree that lifestyle modification, won't be the only path forward to addressing obesity if we do not start to engage our young people, especially at earlier ages, in starting to look at some of those lifelong behaviors that we're developing now at this age range. Because we obviously know, Katie shared all of the comorbidities and life expectancy, everything that's compounded as obesity sets in at earlier ages. We really need to think about how we embed some of those positive behavior strategies sooner than later. Because if we don't, some of the challenges, and one of the specific challenges that we can think of even in trying to do that now is, these are oftentimes, we talked about, and you yourself shared your story about sort of your own self-talk. if our behavior changes and strategies and the current diet or activity we're doing wasn't doing this, if the whole family is not supportive of the young person's behavior change, or even one person isn't, right? Like, all of this, it takes an entire ecosystem to support childhood obesity interventions, and not just the child. The child may actually be willing. It's just a matter of how we make sure that we align up the whole support system to make that support. We had an example of a child in one of our early childhood obesity interventions who's in weight management. The scale wasn't moving at all. And while height was growing and Z-score was changing, what they finally were able to uncover is that the grandfather, who this child spent the first 2 hours after school with every day, his source of pride was the ability to provide for his family, the grandfather. And the child had free reign to everything in that 2-hour block that nobody could find or problem solve. It took a while to figure out where that specific behavior. And again, we have to take into, ethnicity and all of the different cultural not barriers, but even our cultural norms and how we help navigate that. So there are a lot of challenges, but if we don't start to address some of those, that behavior and the modification lifestyle supports at a young age, then it only compounds over time.
Sorry, I'm talking to myself. I'm the moderator and I was on mute. I apologize. I was the first one to do that, so we got it out of the way. So, but I just, Heather, I think those points are so important, right? I think it is more complicated than people think, and I think it's important that we think of obesity, oftentimes as a system and a cultural problem more than just an individual problem. And I think that's the message many of us try to bring forward, is that yes, there are individual aspects of it, but there's actually broader aspects of that are probably even more challenging to control. And speaking of challenges, of course, and I'm going to come back to you, Katie, is that we talked about childhood obesity there, but now I know your work is in older adults. So what are the risks associated with obesity that you see in your work related to those older adults in particular?
Absolutely. So yes, I work with older adults and I love my older adults. They are phenomenal. But before we dive right into the obesity component with aging, I really want to talk about what actually happens with aging, because it's important to understand these two different components. So what actually happens as we get older, we see this decline in muscle mass and strength, and that's commonly known as sarcopenia. It could be primary sarcopenia or secondary due to a chronic health condition. Sarcopenia is really characterized by that decline in physical performance, and as we get older, we will see this decline in energy expenditure, not only due to decline in physical performance, but also due to that decline in muscle mass. And so we don't require as much energy needs. Now, if our dietary patterns aren't changed or our exercise patterns don't change, that we'll start to see a positive energy balance. And next slide. And what that will ultimately lead to is increase in adiposity, increase in inflammation, increase in intermuscular adipose tissue, which then goes on to contribute to obesity. And we start to see this cycle of the muscle itself starts to become infiltrated with fat, so it doesn't work as well. So we see even more muscle loss. And again, that cycle continues on. So this is a common phenomenon that happens in older adults. And again, as we are seeing this increase in obesity in our older adult population, this is very, very common, and it's important to understand. Now, I do want to say that Ricardo makes excellent points, that it's not just about diet and exercise. I'm going to talk about diet and exercise here for the older adult population for two reasons. Diet and exercise can help actually combat that loss of muscle mass. As we get older, energy needs, go down, but we also see this protein resistance, anabolic resistance, this resistance to actually building muscle. And so older adults actually need a higher amount of protein to be able to combat that anabolic resistance. And that's where that nutrition comes into play, because we really want to focus on that muscle. That muscle plays a big role. And then strength training is another really important component that's oftentimes not done in our older adult population. And what that strength training will actually do is really help build that muscle mass. And again, kind of thinking about function and independence. Those are two extremely important things when we think about our older adult population. Independence. If you ever ask an older adult what they want to be independent and stay in their home as long as possible. And so muscle becomes a big component of that. Now, a lot of times in the healthcare system, and this is just the experience that I've had working in two different healthcare systems, is that a lot of times our healthcare providers, not all the time, but sometimes our healthcare providers will see someone with who is obese, and they will assume that they have excess reserve, and so they couldn't possibly be malnourished. And that's completely not the case. For our older adults, when we start thinking about this combination between fat and muscle mass, if we have an older adult who has sarcopenic obesity, that means that they have a large amount of adiposity and a very small amount of muscle, or muscle is infiltrated with that fat. So if you have somebody who's going through surgery, for example, if they have sarcopenic obesity, we want to be able to treat that and think about optimizing those patients before they go into that surgery. And so BMI should not be the category to be looking at specifically for, malnutrition or nutritional needs, particularly in this older adult population. I think that's really, really important as we deal with this increase in adiposity in this population, because we have these two new phenomenons that are co-occurring, this graying of our population, so seeing this increase in the number of older adults, in addition to this increase in obesity. And we know that, again, already more than 40% of our older adults have BMIs exceeding 30. So this is not an uncommon thing to see, particularly in the healthcare system. So really kind of thinking about the combination of obesity with these age-related elevations in metabolic and functional risk, they're going to contribute to more physical limitations and reduced independence, as well as a host of other cardiometabolic disorders. And this really creates what researchers are calling a new phenotype of frailty, the functional frail older adult with obesity. So really important to think about our older adults who do have older adults with obesity in the sense of what's actually happening within that muscle, what's happening in with the body composition. And that's, again, why BMI is really probably not our best measurement for obesity, because, again, it doesn't take into account the composition of the body.
Thanks, Katie. One clarifying question, because it's popped up real quick, and I think it's an easy one we can answer now instead of waiting. So how do you define older adults? What's your age range that we're applying this characteristic to? So.
Oh, please don't kill me. Typically, we start thinking about older adults at 60 and up. I will really quickly say, we start to see changes in muscle mass and function at the age of 40, though. So those changes begin to start to happen at 40 and continue each decade. We start to see losses. So it is important that it is not necessarily age. You got to think about what's going on with the body as well. So, but 60 is usually where we start looking and seeing kind of clear differences.
The other thing that when you talk about obesity and older adults, and this actually applies across the spectrum to people who live with obesity, but it really stands out from your remarks is, sometimes we get obsessed with weight loss, right? But actually the health benefit that we're looking for example, you talking about avoiding frailty is something that I think is a health benefit, and we just have to find better ways to measure that, right? We don't need to think about when you're designing obesity programs, you're offering obesity programs to people. It's not just about getting people to look like a Men's Health or a Women's Health cover model kind of thing. It's actually about improving their health, both physically, emotionally, socially, all those different aspects of it, and that's so very, very important. So.
Absolutely.
So Ricardo, I'm going to jump over to you. And it's clear that there are environmental barriers in accessing effective treatment, and they come to play throughout someone's lifetime, right? But how do you see the social determinants of health impacting obesity? So Ricardo, you're on mute.
Sorry, that's so very important to whenever we have a patient that suffer obesity, we have to address the other components that are not only the physiological components, but what we call the social determinant of health. So if you look at this slide, you can see that approximately 70% of the population as per the CDC live in overweight range. And of course, as Catherine mentioned, it's not the best measure because we're using BMI to define this, but this is what the report is using. And almost 40% of the population in the US live in obesity. So as you can see, the borders, the southeast area are the areas with majority of obesity or prevalence of obesity in the US. And it's a combination of things, probably mix of food from the southern border to the upper part and those high carbs diet that is happening. But we have to take into account several other components. And one of them is the race and ethnicity. We know that Hispanic population and non-Hispanic Blacks are more prevalent to have obesity. There is a genetic component there too, but of course there is other things that we need to take into account. The food insecurity that this population have, the health disparities that this population have, the lack of access to care, the lack of access to job, all of that influence in the process of being healthy. So, and this is, and I always tell this, that in the US, being obese, compared with the developing country, being obese is a disease of the poor. In developing country, being obese is a disease of the rich, because they're the ones that can buy the things. In the US, it's a disease of the poor, because if you take into account, if you go to a grocery store or a restaurant and you buy a salad that is healthy and all of that, costs you $15 or more, and do not provide you that satisfaction that if you go to one of this fast food for this less of that, you get a meal that provides you so satisfaction so you can continue working. So this is something important. And the other thing is the education level. And I want to mention that there is studies that shows that people with high school diploma or higher have less probability of getting into obesity than people that have not a high school diploma. So socioeconomic status, we know that people with higher socioeconomic status have less probability of being obese. And when we compare the household, the people that is below the threshold of poverty have more prevalence of having obesity. So all of this component that usually I can tell from the healthcare provider standpoint of view, we don't think about it because we see a patient and it's organs that we're seeing, but we don't see a patient in a holistic way where all of this other component have to be addressed in that visit. That is influenced by many things, that you only have 15 minutes to see this patient, and how can you address all of the things in that 15 minutes? But all of that things are influencing, and that is very important to make the decision makers, the insurance, the politicians understand that this is as important as addressing the medical part of obesity.
Thanks, Ricardo. And so Heather, I'll jump to you now. So how can the community work to break down some of the barriers that we just heard that prevent people with obesity from accessing either healthcare or community interventions for obesity treatment?
Yeah, so Ricardo set that up perfectly. So, 80% of health happens outside of the healthcare environment, right? That's everything from the policies, systems, and environments that we live in, to in the walkability of a community, if you will, or the safety of a community to be physically active, to where services are offered. And so one of the ways in which your community and community organizations can help support this is really helping to work and meet people where they are. And that's both behaviorally, right? Not just opening access, but preparing for what that looks like, but also then by location, making sure services are being delivered in partnership with the community, not done to, right? Done with. How do we help make sure we're developing interventions that really support people based on what works for them, and taking these programs to places, not necessarily expecting individuals to come to us. And that's something that we've worked at within the Y. And one of the blessings of the public health emergency actually is the fact that we have the ability to do things remotely now if we need to. So how do you build small, form small community and create that environment in which you can foster community to help people navigate both access to healthcare as well as interventions that can support obesity treatment. However, when we think about our community organizations, really ensuring that the staff are culturally competent, right? That they're understanding their own biases, that they're making sure that they're not making assumptions, right? How do we make sure that we really have staff who are representative of the community, who are working in partnership? And in some cases, that may require them to have a better understanding of how to even talk to their healthcare partners. So, don't necessarily assume all your community-based organizations are going to easily pick up the phone and call the, physicians to say, hey, we have solutions. They don't speak the same language sometimes. So really taking some time and working with healthcare partners to ensure that we can ease the burden of referral to community support. That's a big lift. That is not a small thing. And I think there are so many emerging social needs networks out there to help address exactly what Ricardo was talking about. How do we address food insecurity? How do we make sure there's access to healthy foods in a community? How can we help facilitate all those referrals? And in the Y specifically, one of the things that we've done is work. We went and looked for obesity interventions that were proven. So we partnered with Healthy Weight Partnership, who's created the MEND intervention. And we worked on, with them on sort of the Y version of that, which we call Healthy Weight in Your Child. So we're really looking at how can we take some of the behavioral practices we've learned in lifestyle intervention and work with that proven model to address this. During the pandemic, we actually saw higher attendance than we've seen at in-person interventions previously. Now, granted, the families weren't maybe as programmed as previously, or it was a different level, but we've found ways in which even to involve the family, even in the measurements, in taking of the measurements. So thinking about how your community supports can address everything from the social needs Ricardo was talking about to breaking down access, like physical access issues by offering services remotely or going to where the community is. And then really thinking about how you are tailoring your interventions to the needs of the population you're trying to serve. So that's everything from cultural adaptations, which may be around the types of foods that are talked about and discussed, to thinking about and having flexibility if, in our case, for a childhood obesity intervention, and a caregiver has to come with. It may not always be the parent, right? So having the flexibility so that an adult in that child support network can be present. And when we do our physical activity in the program, the adults do it too. It's not just about, so thinking about ways to adapt those interventions to make them more accessible, but also really make sure that we're helping to meet the needs of the populations we're trying to reach and serve. And that just requires us to look at some of those policy systems and environments a little bit differently. It can't just be about, hey, we have a program, you hang up a shingle and people show up. You really have to spend the time to build the relationships, both with the population you're trying to serve as well as the healthcare partners who oftentimes are seeing those individuals, and then going beyond traditional healthcare, because not everybody engages in traditional healthcare. So how might you serve those populations that are not in traditional healthcare, but you may have the opportunity to access through other types of programs and services?
Thanks, Heather. And I think you touch on a topic, and you mentioned it, and maybe we're getting there at the end with your end comments about something I'm really passionate about, and that is the bias that people face because of their obesity. You make it so it's actually not okay, or there's a stigma around actually asking for help or even engaging in one of these community programs. And one of the things, and I know we're trying hard as speakers to do this, and we slip sometimes, but one of the things that we do really encourage people to do is to adopt people first language. So people have obesity, right? They're not obese. For those of us who are going through the learning process, it takes about 2 years to work that vocabulary out of your work that language out of your vocabulary. That's how long it took me personally, not to use it intentionally. So as we work through that, let's be careful with our language. Remember, people aren't cancerous, right? People have cancer, right? Just like people aren't obese, they have obesity. But Katie, I wanted to ask you, I mean, what do you think we can do to help people overcome some of this bias they may have faced, likely at home, but probably even more in the doctor's office? I mean, how can medical professionals help overcome some of that bias?
Yeah, absolutely. So weight bias by healthcare providers still remains to be a complete barrier to obesity treatment. Despite the Medical Association identifying obesity as a disease back in 2013, so quite a while ago, adoption by media, policymakers, healthcare providers has really been very slow. And so the persistent belief that obesity is not a disease, but a lifestyle choice really has a big impact on many physicians' views to patients with viewing obesity negatively or harboring this unconscious bias. And so one of the things that we really need to think about is what happens to an individual when this weight stigma is experienced in the healthcare system? Well, we know that it can lead to avoidance for future healthcare, reduced adherence to services, which is the absolute opposite of what these physicians and healthcare providers are trying to provide, and a lower trust in the communication with the healthcare professionals, which may contribute to reduced quality of care and actually make these health conditions and disparities even worse. So the recognition of obesity as a disease, I think, is the first thing that we need to do for addressing the weight bias. You said it perfectly, right? We think about all the other diseases in a much more of a patient first way. And we need to do the same thing with obesity. So, using that the people first language, where the patient or the person comes first and the disease or the health condition follows. And you're absolutely right. It does take a while to adapt this. And so it's a learning process, and it's something that, we're all working towards. But rather than saying obese patient, we really should try to say a patient with obesity, as we do again with all those other health conditions. And second, we really need to encompass obesity with compassion, with respect, social support, and hope, just as we do with other healthcare conditions. When we think about cancer, I mean, you think about togetherness, you think about fighting together. We don't think that same way with obesity, and that framing really does need to change, because evidence shows that when we frame health conditions positively, like we do with cancer, it leads to increased behavior change. It leads to people actually going and getting their treatment. And it really leads to that healthcare engagement and feeling like you have a partnership, an advocate. The last thing I do want to say is advocacy for yourself and patient advocacy. So that making sure that the patients start, you as a person say, I'm an individual with obesity, is another way to start getting that people first language adapted as well, because it's going to take all of us, but being an advocate for yourself is really, really important as well.
Thanks, Katie. And I just want to pull out a key point that you made in that. And I think, what we often hear from people, both healthcare providers and family members, I'll put them in this place, is that I showed tough love to my patient or to my family member about their weight because it was going to motivate them to do something about it. And Katie, you said this, right? That actually the opposite happens, right? It actually demotivates people and or contributes to further weight gain, and often in many cases. So please, if you see yourself in that scenario, whether it's with a loved one or you're a healthcare provider and you're delivering that kind of tough love care, I would just be very clear. Look at the evidence, because the evidence shows is that actually does not work. It actually causes people to gain more and more weight. So Ricardo, I'm going to come back to you now. So we know, I want to go back to obesity in communities of color, and then we know obesity is also a risk factor for severe cases of COVID-19. How do these disparities we see with obesity relate to what we've seen with the pandemic?
Yeah, so this is a very excellent question, in the sense that we know that COVID-19 pandemic has flourished the healthcare disparities that existed. It's nothing new. It was not created by the pandemic. It was there. The only thing is that it make it everybody aware of it, and then one of the issue has been the chronic conditions, and being so prevalent, as I mentioned in the past, the obesity in the US. That is why we saw different epidemiology from what was happening in Europe at the beginning. I don't know if you remember last year when at the beginning everybody was saying, oh, just the old people were getting the sick, the severe disease and all of that. But when it came to the US, it was a different way. It was a different epidemiology. Young people were also getting severe disease and were dying. And one of the reasons of that contributor was obesity. And obesity is an inflammatory state, as Heather and Catherine mentioned. So you have to imagine that when you have obesity, your body is just producing a lot of inflammation. So then you get another disease that is pro-inflammatory, a virus that is just causing you a lot of more inflammation on top of the inflammation that you have, and then you have the big wound in your body. So that's why it's so important. And I want to use this time to, so important for people that suffer from obesity to go and get vaccinated. Even though you are 13, now we have approved Pfizer from 12 to, so you have 13, or you have 65 or 70 or 30. There is an increased risk that you will get a severe disease. And this is the time that we have something to prevent that. So it's very important to get the vaccine.
Thanks, Ricardo. I appreciate that. And we did see actually with vaccination, now it's open to everyone, but even prior to that, we saw for the first time people with obesity actually being prioritized for care. And I actually thought that was a major victory for those of us that live with obesity. Ricardo, I'm going to stay with you for another question. I know we're going to spend more of this series later on as we get to other webinars talking about solutions, but what do you see right now as the current challenges when you're trying to get treatment for someone living with obesity, coverage issues, et cetera? So.
Yes, so I put this slide because it's so important to understand that the first movement is the lifestyle modification in any process. That's fine. But then when we go to the next step, or the medication or the surgery, look at how poor coverage we have in different states for this kind of medications or this kind of other treatment. So we can see that not even Medicare cover a lot of these issues, and it's so important to do it. And don't think about patients that do not have insurance or have low insurance. They will not have even access to any of this. So this is the cost of the medications are on average of $200 to $1,000 per month. So imagine that's a very big burden on top of eating healthy that is costly in this country, and then doing other things that have to go to a coach or a physical therapist that will cost. So the cost of the management of obesity need to change. And something that Catherine mentioned is that we need to make this aware to the higher levels, the politicians, that this is a disease that need to be changed. We don't have to look, and I loved your analogy with cancer. The other analogies with diabetes is very similar. So we think like, oh, do not eat sweet, and that's it, you will cure your diabetes. No, it's not like that. So we have to take all that into account, and obesity is one of them. The cost for and that's one of the contributors, that the low socioeconomical status, that people that have this advantage and that do not get treated, and the prevalence on those population increase a lot. So just in summary, I want to say that we need to advocate for decreasing the cost of the medical treatment and the surgical treatment of obesity, because really few people can afford them.
Thanks, Ricardo. And I think, one of the things that a number of us on this call participate on and is actually advocating for legislation called the Treat and Reduce Obesity Act, which was recently reintroduced in both the House and Senate by a bipartisan group of legislators. So Katie, can you explain to us how the TROA, as we call it, the Treat and Reduce Obesity Act, would help those over 60, and how you see this fitting into our broader efforts to expand access to obesity treatment?
Absolutely. And just to kind of piggyback off of Ricardo, currently the obesity treatment has limited coverage by Medicare, where Medicare covers surgical intervention, as we saw for obesity. However, it's really important to understand that older adults are at the greater risk for surgical complications, and older adults with obesity have greater risk for infections and poor wound healing. And so, that's something that has to be considered. And also thinking about the non-pharmacological treatment that is covered by Medicare, it does include intensive behavioral interventions. However, they're only reimbursed when provided by a primary care physician. What the research shows us is that the intensive behavioral interventions are really the most effective when administered by an interprofessional team that includes a registered dietitian, nutritionist, physical therapist, psychologists, social workers, and community providers to really help build those behavioral changes into the individual level, the interpersonal, the community, and so on. And I think the last part of this is that the pharmacological treatment is also not covered under Medicare at this time, and that's something that is important to consider. Again, covering surgery versus some of these less invasive treatment options is really something that has to change. And the TROSA bill is one of those things that is actually built to help do that. So that TROSA bill expands upon the Medicare coverage of intensive behavior therapy for obesity. And specifically, the bill allows coverage for therapy that's provided by a physician who's not a primary care physician or other healthcare providers, like a registered dietitian nutritionist. And I think that's really important to understand that most physicians have about 15 to 20 minutes with their patient. And so to be able to do intensive behavior therapy for obesity, it's not possible to do that in a 15 to 20 minute window of time. And it really is important for that interprofessional care providers, those providers, to be a part of that. And additionally, currently, such therapy is covered only if provided by that primary care provider, as I said. Additionally, the TROSA bill would allow Medicare Part B to cover the Food and Drug Administrative approved obesity drugs, which again would be another big win in regards to less invasive obesity treatment options. And as we know, once Medicare kind of jumps on board, other healthcare providers, typically other insurance companies typically do follow suit. And so this is hopefully will be a trickle down effect where we actually see not only Medicare, but also other insurance companies follow suit.
Thanks, Katie. And I wouldn't be doing my job if I didn't encourage this, but as someone who's championed now the Treat and Reduce Obesity Act for almost, I think, 5 Congresses now, it is time for this legislation to pass. It is obviously the pandemic proved that to us, that obesity is something that can harm you today, not just tomorrow. And so we need to do more about it. So there is a mechanism for you if you want to support this bill and write your members of Congress. You just have to go to obesitycareadvocacynetwork.com/advocacy, and you can actually write to your member of Congress and urge them to support this legislation. So I want to thank all of you for your insights. And now we're going to move to some audience questions. Again, if you have questions for our panelists, please open the chat box and send us your questions along with your name and affiliation. As our audience readies their questions, I'll kick off with some. And I think, Heather, I'm going to come to you first, actually. How can we incorporate behavioral health into the prevention and treatment of obesity? What are your thoughts there?
Yeah, I mean, I think Katie actually just said one of the ways in which that can happen is if you have an interdisciplinary team, include the community. Because again, so much of the behavioral supports that individuals need in order to work, through what they're experiencing, whether it's in prevention or treatment of obesity, requires community support. And so, yes, we want to make sure that we're not just covering the care, in the health care side of things, that we're also covering the prevention side of things as well. So that would be one place that I would say, think about your community resources, think about your community organizations who can help support patient journeys through this. The other thing is, I'll tie back to what you yourself said, Joe, around the tough love physicians and family members, right? It's not just physicians, I'll say that too. There's a readiness for behavior change that has to be taken into account here. While, and we've been working in the diabetes prevention space for over a decade. We've been working in childhood obesity, lots of different chronic conditions that we've been working in. But what the common denominator in all that is a readiness for behavior change with the individual. And the more times that there is perceived failure, the less likely someone is, and oftentimes the less ready someone is. So I think we really need to look at how we incorporate readiness for behavior change, even in the clinical environment, in order to help route people to the appropriate level of intervention that they're ready to start with. And it might not be where we want them to end in our clinical care continuum, but if we don't set people up for some successes with SMART goals and wins out of the bat, right away, you're just setting people up for further failure, and that can compound both that anxiety, depression, et cetera. So I think one of the things that we have to be thinking about is how can we make sure readiness for behavior change happens not only in the clinical environment, but even when, as community organizations, if we get referrals for different types of interventions, how are we assessing someone's true readiness? And how do we help someone see these behavior changes as a continuum so that they can start and have some wins? Sometimes just making that call from referral to the intervention is the biggest win that someone will have, right? But you have to start small and you have to meet people where they are. And if we don't start putting some of those behavioral strategies, because 15 to 20 minutes with a patient, once ever, whatever periodic interval you name, no. You need, the types of behavioral strategies and supports it takes to actually make, it drives me crazy even when people say it takes 3 weeks to form a habit. I'm like, maybe 3 weeks if it was 24 hours a day. I mean, maybe. We're really talking about long-term intensive support that takes much, with strategies and support built in to help somebody be successful. It is not, meet your physician every 6 months and hope that the scale doesn't move in the wrong direction, right? It's how do we help people meet them where they are? And that's really requires embedding a lot of those behavioral strategies, both in the clinical side, but also in including the community side in the support model.
Thanks, Heather. And I think I'm hoping the audience is as encouraged as I am by listening to you and Katie and Ricardo about this. And And if you are a person like me who lives with obesity, just know maybe in the past you haven't had the best experiences in either your community or your healthcare environment, but the world is changing. And so it is okay to ask for help if you need help to address your obesity. And I would encourage you to do it and try again. Take that step, right? I think most of us wake up in the morning and know we struggle, right, kind of thing. But we've always thought, well, this is our personal problem, and we have to deal with it on our own. But this whole conversation today is about shifting that, right? You don't have to do this on your own. There's help out there. And by the way, if you don't find it right away or you have a negative experience, keep looking, right? Because there are committed people, as you can see from our panelists out there today, who are trying to do this in a way to really benefit people who live with obesity. So I wanted to, there was a question early on in the chat that I wanted to address, because I think sometimes when we talk about the Treat and Reduce Obesity Act, we forget that actually not everyone who is on Medicare is a senior, right? Or is an older American, right? Actually, we have people who live with disabilities, both intellectual, physical. They may have kidney failure, end-stage renal disease, et cetera. And I just want to be very clear that we do believe that the provisions of the Treat and Reduce Obesity Act would apply to the entire Medicare population. There's actually specific needs, I think, in many of those populations for obesity care. So keep that in mind. And then the other key thing, and Katie said this, and I'll repeat it here, is even if you're not covered by Medicare and you're covered by private insurance or say another state health program, a Medicaid program or something like that, what Medicare does, the other insurers follow very quickly. And we have plenty of examples throughout history. So I have another interesting question. I'm not 100% sure who to ask this to, so maybe Katie or Ricardo, you can split this up. But what considerations should we keep in mind to support people with, genetic mutations that may increase obesity? I think we've heard more of that recently, especially around childhood obesity, as a new drug came out specifically for children with a specific genetic mutation. But would either of you like to comment on that?
I can start, and then Katie can continue. So whenever we have to see that from the 100% cases of obesity, probably 4 to 5% are caused by monogenic causes of obesity. This means that is a genetic condition behind it. And really, none of the things that we are talking about for the 95% of the people will work, because there is a mutation and there is something else happening on those persons. So the good thing is that the research advance on those monogenic causes of obesity has increased a lot. We have a melanocortin receptor 4 antagonist that is one of the mutations that can happen that is approved recently, and that will work specifically for that. We have other drugs that are in the pipeline that will work. So it's very important when you are evaluating a child that have obesity to evaluate if this is a monogenic cause, because then the treatment will be different. And those patients definitely have to be referred to a specialist, obesity specialist, so they can be treated adequately with the new drugs or what is in the pipeline. So that is a different type of approach than the approach that you will do with the general population that have no monogenic causes of obesity.
Katie, anything you wanted to add to that? Or I think that covered it pretty well.
No, I think
right?
he covered it perfectly. Yeah.
All right. So there's another interesting question in the chat around convincing organizations that where obesity needs to be addressed, right? And actually, I think for me, it's an interesting question, because they're actually saying, well, how do we convince PCPs instead of referring out? And actually, I think my view would be, and I think maybe you all agree, is that we need to use all the tools that are out there, but our primary care providers play a key role. So I don't know if anyone has any insights on kind of cross-linking primary care providers to community programs and or more specialty programs.
So I'm just one thing that I think is really important when we think about the referrals, I think a lot of our healthcare providers may not even know how to refer or what to refer to, or what interventions are out there. And so honestly, I really do think that there needs to be a little bit more education that goes to our PCPs to help them understand how to refer out. I mean, I work with a very interprofessional team. And we were kind of in awe the other day when we came across a speech language pathologist who didn't know how to refer to a registered dietitian. I mean, and these are pretty close, we're doing the same, we're looking at the same thing and trying to help people get food in their bodies. And so again, this is not something that is uncommon, where we all work in, a lot of us work in silos. And I think kind of communication from the community is really, really, really important. And getting those healthcare providers invited to community events, community organizations, what's going on. It's another wonderful way, I think, we can kind of bridge this gap as well with referrals and also educating our PCPs, because again, they are thinking about a lot of different things. And so it is important to make sure we do educate them as well.
Heather, I'm curious if you have any, I was going to ask you any insights from, I know the Y has a lot of programs here, so go ahead.
Yeah, no, it is hard, right? Like healthcare providers have a tremendous amount of work on their plate, trust me. So, I guess my recommendation would be to the community organizations to make it as easy as possible. Think about things in the terms of their workflow, how might you help? And it's not always the physician, the whole care team, right? If there's a care coordinator, if there are community health workers, who might you need to be able to work with there? I think on the flip side of that, not all patients have primary care. So how are you getting to even, if folks are showing up in the emergency room for XYZ, how are we helping to make sure they're getting treated within the health system beyond that and getting referred and getting things flagged? Like there's lots of different ways in which we need to be approaching. I think, Joe, I agree with you. It's an all hands approach. We just have to figure out how best we can make sure that we're, all communicating as efficiently and effectively as possible.
Right, and I do actually think that as we improve reimbursement across the spectrum from all of this care, then that is actually part of the system that, right now we're all in silos because we're trying to fight for whatever reimbursement we can get but as we make reimbursement available for everything, then we'll actually create a system where people can communicate better around this. And so, Katie, I know we are running out of time, but one quick question for you from the chat was related to, and this may not be a quick question, but related to menopause and adiposity in older women. So do you want to add any insights there before we wrap up for the day? So.
Yeah, I think kind of going back to the sarcopenia component, we do see that loss of lean muscle mass. We also see a redistribution with menopause and also lower testosterone. So all of our sex hormones contribute to kind of change in body composition and impact muscle mass. And for women, what we often see is a reduction in muscle mass around the arms and legs and more adiposity, central adiposity around the hips and abdominal section. And so it is a change with the hormone levels. It's also an impact of that anabolic resistance that we see due to the sex hormones. So all of that, there's hormonal factors, there's exogenous factors. So, activity, dietary intake, any potential drugs or diseases that might actually be increasing inflammation, causing a little bit more changes within the body is also going to happen. So it's a combination of everything. It's not just one certain thing, but oftentimes we will see the increase in body weight with the change of body composition and that decrease in lean muscle mass or fat-free mass. So.
Thanks, Katie. Thanks, Heather. Thanks, Ricardo. We are out of time today. I want to thank all of our panelists and all of you who were participating in the audience this afternoon. You can continue the conversation with us following OCAN on social media. You see the links listed here on the screen. It's Twitter, it's obesity at Obesity Advocacy, and by searching for Obesity Care Advocacy Network on LinkedIn. Please join us for the next webinars in the OCAN Summer Webinar Series hosted by the YMCA of the USA. Looking forward to Heather's taking care of that moving forward, taking on these, I think, my duties that I'm having right now. But those will take place in July. The first in July, which is community partnerships are vital in addressing obesity. And then the last of them is in September, supporting children physically, mentally, and academically as they re-enter a traditional school year. More details on both of those programs will be sent to everyone who registered today as they are finalized. And thanks again for your participation in today's program. I'll leave you with two asks, right? One is two calls to action, and one really is help us in our fight to improve access to obesity care. So, whether that's supporting the Treat and Reduce Obesity Act or supporting something in your own local community to improve access to obesity care. That really will benefit those of us living with obesity. We're really only going to tackle this epidemic by actually giving people the help they need. And then finally, participate in our efforts to reduce weight bias, right? We are not going to motivate anyone to address their obesity by shaming them. We're only going to do it by supporting them, treating them with empathy, and treating them with compassion. So thank you very much for participating.